Hi, Kate Grace, physical therapist, orthopedic physician assistant. Welcome to another great podcast, Move Without Limits. Today, we are honored and very blessed to have one of the experts in the world in stem cell treatment. You might have heard his podcast many months ago, Dr. Chris Rogers, but we're bringing him back because it seems like every month there's new data, there's new research, there's things happening all the time. And we wanted him to come back and give us an update specifically on stem cells. And also, we got a lot of questions from viewers in advance, and Chris has kindly agreed to answer those. If I ran through all of his accomplishments and accolades starting way back, it would take up the whole podcast. So I'm just going to say the most important things are that he's a board certified physical medicine rehabilitation specialist. He's a world leading expert in regenerative medicine. He is a brilliant diagnostic ultrasound specialist. But what I love about him the most is that he always does the right thing. And he always does the best thing for his patients. Takes time. He's a great diagnostician, and he does treatments that actually work in a very low risk, high reward situation. So that's, and the other most important thing, he's my friend.
Yeah.
And I love collaborating with him because it's always special, and we always do right by our patients. So let me bring Chris into the studio once again. Hi,
Hello.
Chris.
Hi, Kate. Great to see you.
You too. Dr. Chris Rogers has taken time out of his very busy schedule to talk to us today from his office. And so I thought I'd let Chris start by talking about, a lot of people don't know what mesenchymal stem cells are and what's new. So maybe you could enlighten us.
Well, we've now known about stem cells since the 1980s. So, in the scientific community, not that new. I think the public became aware of it in the early 2000s, maybe late 90s. But stem cells means many different things. I'm talking with you today specifically about the mesenchymal stem cell, a cell that was discovered at Case Western in Cleveland by our friend Dr. Arnold Kaplan, who was able to discover this cell that lives in many of our tissues in our body that he was able to show could differentiate into other cell types. And that was exciting to think that there was this cell that could turn into a bone cell or a cartilage cell or a heart cell. Since then, we've learned many more things about this particular cell, the most exciting of which is that it is actually part of our natural first aid kit. So when we are injured or we're fighting disease, these are the cells that help us do that. And they are rapidly being translated into treatment options. And my specialty is in orthopedics, so we see a lot of difficult to treat conditions such as arthritis or tendon tears or disc degeneration, for which stem cell therapy very likely will become standard of care for treatment. The mesenchymal stem cell also can be called the acronym MSC. Dr. Kaplan asked us to not call it a stem cell, but to call it a medicinal signaling cell. Medicinal because it's a little pharmacy, if you will. It's manufacturing proteins, growth factors, cytokines. It's releasing packets of information with DNA and RNA. It is essentially medicating the damaged tissue in our body. So if we have, for example, knee arthritis, we have cartilage damage, that cell has the ability to inform the cartilage cell how to function more properly. It also has the ability to suppress the immune system so the inflammation can be decreased and the pain can be decreased. It literally secretes opioid peptides, so you know what endorphins are. It secretes these peptides that function as a painkiller. So when we put these cells in the body, they are helpful for relieving pain. And really, the list goes on and on. These cells are really exciting, and we're learning new things about them all the time.
Stem cells. How do you extract them and use them in your patients?
So the mesenchymal stem cell, in its native form, lives on the surface of your blood vessels. Okay, and presumably was placed there because when there's tissue damage, there's disruption of the blood vessel, and the blood vessel releases the cell into the tissues. The cell can be found pretty much in any tissue within the body. The first place it was discovered, of course, was in the bone marrow. But then later it was discovered that these cells also exist on the blood vessels in our fat tissue. And that's where most of the research has been done. But literally it's everywhere in your body. It's in your heart, your brain, your liver, your kidney, anywhere where they might be needed, of course. The third tissue that you hear commonly referred to as an area of interest in research would be from the umbilical cord tissue or from what we call perinatal tissue. So the placenta, the umbilical cord tissue or the umbilical cord blood does contain a small number of stem cells. These have also been studied as well. My particular research is focused on the patient's own stem cells derived from their own fat tissue. Most of my patients are more than willing to give up 4 tablespoons of fat. And
then some.
Yeah, and then some. And I'm not a plastic surgeon, but I do know how to collect 4 tablespoons of fat, and many other doctors do as well. And it's a very benign procedure. Actually, we've been using fat itself, the entire fat tissue, not just the stem cell component, but all the other cells in the fat tissue. We've been using it as a treatment for over a decade and a half in orthopedics. We've been using it for treating tendon injuries and arthritis as well. But to get a high enough number of these cells, we have to first extract the fat tissue. And this is done with the company for which I work. It's called Personalized Stem Cells. And they developed this technique back in 2002. So the technique's been around for a long time. The fat tissue is sent to the lab. This is an FDA regulated lab. And then the stem cells are released from the fat tissue by the use of enzymes and centrifugation. And then those cells are plated on a petri dish and they are fed culture media so that the cells can grow in number. So from a small number, maybe 1 million stem cells, mesenchymal stem cells from the fat tissue, we can grow a lifetime supply of treatments, potentially tens of millions, hundreds of millions of cells from a single simple lipoaspiration procedure. So that's the most common way to get these cells these days. Bone marrow is another, and then donated fetal tissues also. I mean, not fetal, but perinatal tissue.
Okay. So, and you've told me this many times, if it comes out of you, it's a stem cell. So what's not a stem cell?
Oh, well, there are many treatments that physicians will offer to their patients that often get mislabeled as stem cell therapy. So for example, 15, maybe even 18 years ago, a common treatment was to extract bone marrow from the pelvis. So your own bone marrow, we would simply stick a needle in your pelvis. We would aspirate the bone marrow. And there are mesenchymal stem cells in there, but very small number. I told you 4 tablespoons of fat gets you about 1 million stem cells. 4 tablespoons of bone marrow gets you about 100,000 or less stem cells. So it's a very, very, very low dose. It's really not a stem cell therapy per se. Matter of fact, 99% of the cells are other cell types when we do a bone marrow aspiration procedure, or what's commonly referred to as BMAC, bone marrow aspiration concentrate. It's effective, but it's not stem cell therapy. It has stem cells in it, but it's like I say, it's less than 1% stem cells. PRP, which we do, platelet-rich plasma, where we draw your blood, concentrate the blood. Those are platelets. Those are not stem cells. So sometimes people get confused and call it stem cell therapy. That is not stem cell therapy. The other thing you'll commonly hear is doctors will offer their patients treatments derived from products that have been derived from perinatal tissue. So like I said, umbilical cord blood or umbilical cord tissue. These products are sterilized. They are gamma irradiated to kill the bacteria that might be in the tissue. And as a result, there are no living stem cells in those products. Furthermore, even if there were living cells in those products, we as physicians in the United States are not allowed to administer those therapies until they have been proven to be safe and effective according to FDA standards, and that has not happened yet. So what I've told you many times is that if a doctor offers you umbilical cord or Wharton's jelly or umbilical cord blood stem cells, just understand that that's not stem cell therapy, and even if it were, it's not a FDA approved legal product.
Okay. And you've also always told me that if it doesn't come from you, it comes from a bottle, it's not stem cells.
Yeah, again, those products are irradiated. Now it's different if you go overseas, right? So if you go down to Mexico, like many people will do, or go to Panama, those are probably live cells, but there's challenges with those products as well. Those products are derived from a donor. We now know that your immune system has a tendency to attack and kill the stem cells that are infused into the patient. Many patients will describe a mild low-grade fever after receiving treatment when they go overseas. It's not harmful, doesn't appear to be harmful, but if you were to measure antibodies in the blood, you will see that your body is manufacturing antibodies against the foreign DNA, the foreign proteins that are being injected into those patients. We don't yet know what the long-term safety issues might be. So I generally advise patients until we have that data to avoid having somebody else's cells injected into your body.
Okay. And what are the clinical applications for stem cells? What kind of patients do you use it on, and for what reason?
This is probably the most exciting thing. This is why the whole medical community and scientific community is excited about these cells, is the number of potential uses is beyond our imagination. Like I said, originally it was thought that these cells would differentiate into different cell types in your body and presumably are replacing damaged or diseased cells, but it goes way beyond that. The fact that they're so potent with their ability to modulate the immune system, decrease inflammation in the body, means that they could potentially be used for a host of autoimmune diseases, things like rheumatoid arthritis or multiple sclerosis. So there's really a lot of excitement in that area. There's excitement in the area of neurodegenerative disorders such as Alzheimer's or Parkinson's disease. A lot of research currently going on in that space. In my neck of the woods, I'm interested in orthopedics. So, I've been treating patients for almost 30 years who have chronic osteoarthritis, knee arthritis, hip arthritis, shoulder, chronic tendon injuries, tendon tears, rotator cuff tears, for example. And then the big one, of course, is chronic low back pain due to disc degeneration or arthritis in the low back. And I think all of these areas, the data is emerging showing that all of these areas are potential for using stem cell treatment, using mesenchymal stem cells to treat those conditions, not just to suppress symptoms of pain and inflammation, but also to regenerate healing of those degenerated tissues.
Exciting.
Yeah.
I know that I've seen you do this many times, and one of the things that, of course, sets you apart, so many things, is that you use fluoroscopy when you're injecting into the spine, and there it is.
It just happens to be one right here.
And diagnostic ultrasound. So there's you doing some fluoroscopy. We just give a little quick, like, what is that? And we can talk about diagnostic ultrasound.
Yeah, fluoroscopy is a way to allow us to see into the body as we are injecting a substance. So originally we would inject cortisone, epidural steroid injection, the most common procedure in the United States. Over 11 million people getting epidural steroid injections a year for herniated discs and sciatica, spinal stenosis, these kinds of conditions. We used fluoroscopy as a way to safely and comfortably guide a needle near the nerve or in a joint or in another structure, and like I say, to provide safety and efficacy as well. And that's very different than when I was in medical school, where everything was done by feel. We weren't able to look into the body in real time. So fluoroscopy has been around now for several decades. It's the standard of care. Do not let anyone inject your spine without using it. For peripheral joints, shoulders or knees or hips, we're more likely to use ultrasound guidance. That's also real-time imaging. So we're using ultrasound waves to see those tissues. And when we do our injections, we can guide the cells directly, to the injured sites.
I think we have a picture of you of it's non-invasive. You just have a little probe over the joint and you're
Yeah.
looking at it. And then I think we have an image of what it looks like. And to a lot
Yep.
of people, it looks like a bunch of black and white. But to you, I know
Yeah.
exactly what you.
Yeah. To me, when I went to my first lecture in the year 2000, I think it was, I thought the guy was pulling my leg. I'm like, I don't know. I don't see what you're seeing there. But I have to say, after 25 years, I cannot not see that this is a patient's knee. They have osteoarthritis.
Yeah.
The bone is the bright white signal, so the femur and the tibia are labeled there. The meniscus is in the joint space between those two bones. So you're looking at the inside of the patient's knee, the medial side of the knee. And then the dark area above the bright white area is the ligament, the medial collateral ligament. So as you can see, in real time, we can get very detailed information. I don't think people realize that for tendons, for example, ultrasound has 10 times the resolution of an MRI. So I actually prefer ultrasound. I mean, I do both, but I prefer ultrasound because I can quickly in the office just put the probe on the patient's shoulder, their knee, their hip, and get them a diagnosis right away.
And what I like about watching you do that too is, like, for the shoulder, you can move the joint and see if they're getting an impingement or not. And when you do a PRP injection or something, you can see the needle go right to where it's supposed to, and you can actually see those little cells diving in to heal that tear. So it's amazing. I see, oh no, he just kind of went like this and stuck in my shoulder. You might as well close your eyes and, take a step.
Yeah, there's numerous studies now that have compared the old technique for a knee injection, for example. There's about a 30% chance that you're not going to get that needle where it needs to go, or if you're lucky enough to get it where it needs to go, you're going to do it in a way that's less comfortable than it should be. With ultrasound guidance, I can direct the needle exactly to the target. I can anesthetize the tissue first, and it's very comfortable, very safe, and most importantly, it increases the effectiveness of the treatments. A lot of times we'll see patients who maybe had, say, for example, a PRP injection done elsewhere without the benefit of the guidance from the ultrasound, and the result wasn't good, and that was simply because the cells did not go where they needed to go.
Exactly. Well, that leads me to the first question, which I had to laugh at this because I get this all the time, and I'll read this specifically because this is what they said. What's the difference between Dr. Rogers' results versus the doc in the box?
A doc in the box. I've never seen a doc in a box, but I know what they're saying. Yeah,
these guys who go, to a weekend course and then call themselves regenerative medicine specialists. So can you just comment on that? Because I get the same thing. I don't want to interrupt you, but I see a patient and I say, well, I think they've got a lateral condylitis or something, tear, and I said, you really should go see Dr. Rogers for this. And I had PRP. He said, that didn't work. I said, well, where'd you go and what'd they do? Well, they went to a doctor who's only been doing it for a day and didn't use diagnostic ultrasound. So it wasn't done the right way, as you said. So of course the results are going to be a little bit different. So that's the question.
Yeah, there's four, I'll tell you my secret sauce. There are 4 ingredients in our secret sauce. Ingredient number 1 is you have to have an accurate diagnosis. It doesn't matter how good your treatment is. It doesn't matter how amazing your surgery is. If you treat the wrong problem, you're not going to get the outcome you want. And not only is the diagnosis correct, but it's complete. So for example, you may come to me and I look at your x-ray and I say, well, you have arthritis. But then I look at the ultrasound, I'm like, oh, you also have some tears in your ligament and your tendon and maybe your meniscus. And if I don't treat all the injured areas, the results are not going to be as good. So a complete, accurate diagnosis is the first ingredient in the secret sauce. The second is use good products. What I mean by that, we early on when we started using platelet-rich plasma, the dose was too low. We would have about 2 to 3 billion platelets in our treatment. And we now have good evidence that if you don't have at least 5 billion platelets, the results aren't going to be nearly as good. Well, how do you know if you have 5 billion platelets or not? You have to use a method that gets you to that number, and then you have to have a cell counter in your office that actually counts the cells before you even think about injecting them into that patient. So that's number 2, good product. Or actually cheap promotional here. For behind me is the company I work for, Personalized Stem Cell. In that box are stem cells that have been grown in culture at our lab here in San Diego. And this lab has been manufacturing cells now for over 2 decades, starting originally with veterinary medicine animals, so patients, horses, cats, and dogs. That is a high dose of stem cells. That is, you're talking 10 to 20 million cells in a vial. That product has also been tested for sterility. There's no bacteria in that product. There are no fungi in that product. So second ingredient is make sure you have a safe and effective product, whether it's PRP or bone marrow or fat stem cells derived from fat. Number 3, we already talked about. Make sure you put those cells where they need to go. Use your fluoroscope, use your ultrasound machine to make sure that you're putting those cells not just comfortably, but effectively in the injured tissue. And then step 4, train that patient how to take care of their body so that they don't get injured again. Refer them to an excellent physical therapist. We can talk about the work that you and I have done developing post-treatment protocols over the years so that we are progressing the patient through the healing phase because it does take time for these cells to work. And they have to be guided through proper exercise intensity and type. So those are the 4 ingredients: accurate diagnosis, see somebody who is a specialist in your area that you need. I'm not a cardiologist. I'm not going to treat your heart, but I can treat your knee. Good product, good technique, and then good rehab afterwards. You do those 4 things correctly, your outcomes will be very good.
Fantastic. And I'm glad you mentioned the PT because we talked about this early on. You go all over the world and you speak at all these conferences. And I said, well, Chris, what's the post-injection protocol? Well, they don't exist. So we created them. And what's important for our listeners to hear is that Chris can inject your tendon and heal the tendon. But why did it tear? So there must have been some mechanical abnormality to get you there, whether your shoulder was so far forward that you overused your elbow, or your head was so far forward it strained your neck. So you have to see a really good manual physical therapist to correct all those mechanical faults, postural faults, inflexibilities, weaknesses, so you can maximize the benefit of the injection.
It's absolutely right. There are predisposing factors that led you more than likely to develop the rotator cuff tear or meniscus tear. But then there are also physical conditions that have developed as a result of having that tissue injury. You're not walking as much as you used to. You're not exercising as much as you used to because it hurts. Mm-hmm. And so you're deconditioned, your muscles get tight, they get weak. So at a minimum, you have to be reconditioned once your pain is gone, once your tissues are healing. So those 2 things are critical.
So our lovely producer is going to ask a question.
What conditions do stem cells help the most?
Did you hear that, Chris?
I did. So when I answered the question like that, I answer from 2 podiums. Podium number 1 is the published scientific evidence in the peer-reviewed scientific literature. For example, the most common thing I hear is that my old stem cells are not as good as young umbilical cord stem cells. And the data would argue the exact opposite. If you look at all the published papers on using patients who are in their 60s and 70s and even their 80s, the outcomes for knee arthritis are actually superior than those published studies that have used, essentially newborns tissue. So it goes completely against common sense may dictate, but you can't argue with the published evidence. So that's predominantly for knee osteoarthritis. Everything I'm saying comes from the perspective of a specialist in orthopedics. It may be true that in the future, a patient who has an autoimmune disease might benefit from a donor's cells, in that case, but that has not been proven to be the case just yet. So what does the peer-reviewed scientific literature say? Which conditions are for which there's greatest benefit? Bar none, around the world, whether you're in Asia or Europe or Australia or United States, the studies show knee osteoarthritis extremely effective, so effective to the point that patients can get 4 years, 5 years relief from a single treatment. And most studies show benefit in terms of healing the joint. So we see thickening of the cartilage. We see decrease in the size of the lesions that are in the cartilage. We see increase in density of the cartilage. There have been cases where the cartilage has been biopsied. It is legit hyaline cartilage, not fibrocartilage like we see with some other techniques. So that's where the lion's share of the scientific evidence is found. Rotator cuff tendons, there is also very good evidence that full thickness, high-grade tendon tears are amenable to stem cell therapy. There's been kind of a rocky start with treating non-orthopedic conditions. So, for example, myocardial infarction or stroke. But there has been some good data on heart failure, evidence that you can improve the function of the heart. There's some emerging data on the use of treating patients with multiple sclerosis, showing that many of the symptoms of multiple sclerosis can be ameliorated with stem cell therapy. There is a condition that you may not have heard of, but you're probably familiar with the concept of an organ transplant. And when a patient gets an organ transplant, sometimes the cells in the organ attack the actual patient. It's called graft versus host disease. This past year, the FDA approved the first ever stem cell therapy to treat kids who had graft versus host disease. So that was historic. We should celebrate that finally now the U.S. has an FDA approved stem cell therapy. South Korea is at least 10 years ahead of the U.S. They approved the use of stem cells for knee arthritis more than 10 years ago. Japan has done the same. So another condition for which there is good evidence is something called Crohn's disease. You and I know someone who's afflicted with Crohn's disease. Crohn's disease is an immune disorder that affects the intestine and results in intestinal symptoms, diarrhea, bleeding, etc. Stem cells have been shown to be useful for treating that condition as well, and it is approved in some countries for that indication. So we're really just at the very beginning. There are about 10 medical conditions that are approved around the world, but that's going to grow very quickly in the next 10 years.
Oh, that's exciting. Okay.
How long do stem cells take to work, and how long do the results last?
Great. So I'm going to focus on orthopedics. If you are treating osteoarthritis is a very complex disease. It is a chronic low-grade inflammation of the joint, which damages the cartilage and causes chronic inflammation in the joint. It doesn't matter how well you eat. It doesn't matter. I mean, it helps a little bit to get the systemic inflammation down, but these patients still have chronic low-grade inflammation in their joint. Stem cells will bring that inflammation under control in about 60 days, and you will start to see changes in the cartilage tissue on MRI as early as 6 months, more typically 12 months, or when studies are showing the benefit. So even though patients are symptomatically improved within the first 2 to 3 months after treatment, the actual objective changes on imaging aren't seen till more like 12 months. There was one study published out of Asia where every year following a stem cell therapy, the patient had an MRI of their knee, and benefit was shown to improve by year 1. By year 2, the cartilage was even thicker still. By year 3, even thicker still. Even though no additional treatment had been done, you're still seeing benefit healing in the tissue. By year 4, it had plateaued, and by year 5, it was starting to decline, but it hadn't declined to the baseline. So that's the longest study, that well done study in the published scientific literature, 5 years from a single treatment. So that's the first podium, is the published literature. The second podium is my experience. My personal experience, having treated many patients who qualify for what's called expanded access or compassionate use, or under the Congress-approved Right to Try Act, is pretty consistent with the published scientific evidence. We do not yet have 5-year outcome data, but we do have 2-year outcome data showing that the vast majority of patients who have knee arthritis, shoulder arthritis, hip arthritis, or arthritis in their lumbar spine are still doing well after a single treatment, at least 2 years later. And then finally, I will share that I actually did a FDA-approved clinical trial using patients' own stem cells for the treatment of osteoarthritis. All these patients were told they needed knee replacement. We were able to prove that 2.5 years after a single treatment of patients' own stem cells, we were able to show that nearly 80% of the patients were able to avoid joint replacement surgery. So this has the potential to have huge impacts on the management of knee osteoarthritis going forward.
I want people to really get that they can realize the benefits from one injection for potentially 5 years.
Yeah, there's nothing else I have in my toolbox that I can inject into your knee that will give you 5 years relief, which is why I'm so excited. Now,
Okay.
the truth is there are patients where they won't get 5 years, but the good news is once we collect your cells and grow them in culture, we then freeze them and bank them in cryopreservation, and they can remain in that state for decades. So if I treat your shoulder today and you're great for 2 years, but then 2 years you come back and say, my shoulder bothers me again, those cells are there waiting for you, and I can then treat you again. And I think that will be necessary for probably 1 out of 5 patients. But for 4 out of 5 patients, that one single treatment will last many, many, many years.
That's so exciting.
Yeah.
Question?
What age is too old or too young for stem cell therapy?
Good question. On the too old side, if you're breathing, you're a candidate. We have actually, I've had 90-year-old patients tell me my old stem cells are no good anymore. I'm like, do not speak badly about your cells because they are keeping you alive. But we actually, one of our patients was treated under one of our clinical trials. I think he was 92 and had very good relief of his arthritis pain. So, and we're not the only people to have done these studies. There are published studies on octogenarians showing high success rate using their own stem cells. So I really don't think there's an upper age limit. On the low side, we generally younger patients don't have the advanced disease that those of us over 50 have, right? So I see a lot of young soccer players or young, football players who have damage to their tendons or to their cartilage, but it's generally mild to moderate. And so we can manage them with other treatments. And there has not been a lot of research on the young population. So I would say we're still very early in our understanding of how to treat those young people.
How about in your practice? What's the youngest patient you've treated?
I think the youngest patient I treated was probably in his mid-30s.
Okay, that makes sense.
Had severe osteoarthritis and told that needed, joint replacement surgery at 35. And
that'd be a disaster.
We don't expect that surgery to last the rest of that patient's life, and so this is somebody who should consider alternatives. But yeah, generally my average patient's in their 60s, I would say.
Okay. And I tell people, and I'm sure you do too, you can always do surgery. You can't undo surgery, but you can always do surgery. So why don't you try something a little bit more conservative first with phenomenal results? Question?
Yeah, there are, I want to be clear. I've worked with surgeons my entire career. I was in the Department of Orthopedic Surgery at UCSD for a number of years. So I have healthy respect for orthopedic surgery, and there's definitely need. But I think the goal is to treat conditions with less invasive surgery. And then for those who can be treated with non-surgical methods, let's do that, right? So I think, obviously there's some risk associated with big procedures, so we want to minimize risk to our patients. But there are patients I've seen who, for example, I recently saw a patient who severe shoulder arthritis, couldn't raise his arm more than a few degrees. And I said, yeah, you need shoulder replacement. We're not gonna be able to help you with a injection. Had I caught that patient a decade earlier, perhaps I could have helped him.
Okay.
How do you prepare your body before a stem cell procedure for the best results?
I would say everything falls within the category of physical therapy. Good conditioning. So, I mean, I'm not a perfectionist, but every day you don't exercise is a lost opportunity. And aging does not sleep. So, life happens. We get injured. We have issues to attend to in life. But if it takes our eye off the ball for too long, we can become severely deconditioned, which makes it harder for us to recover from injury. So many patients who I see have been suffering for years with a painful back or a painful knee or a painful shoulder and have not been able to optimize their exercise. So I would say anything we can do in the exercise category will optimize the outcome. There is some interesting evidence that certain medications may impact the benefit of stem cell therapy. So, for example, we wouldn't necessarily inject cortisone into your knee and then 2 weeks later inject stem cells. I think there's pretty good evidence that that's not a good idea. But if we let several months go by, I think we're fine. There are patients who are dealing with other medical conditions that need to be optimized. So they may have autoimmune diseases or other maybe metabolic disease that should be optimized. So it's on a case-by-case basis. But in general, for orthopedic conditions, anything we can do to help you maintain your aerobic capacity, to improve your mobility and your strength is how we get our best outcomes.
And I tell people over the age of 30, resistance training is non-negotiable. And you and I can talk about the musculoskeletal benefits all day long of your joints are only as good as the muscles to support them. But how about the metabolic benefits, the brain benefits, everything else? So yes, if you do resistance training, you stay strong, your results and recovery will be optimized for sure.
Yeah, I think we're at the point now where we all agree that exercise is non-negotiable.
Yeah,
and
good.
And in all category, right? I mean, actually, steps per day, which is a proxy for VO2 max, essentially your aerobic capacity, are the greatest predictors of longevity, right? And also predictors of quality of life.
Mm-hmm.
And so for us to deprive ourselves of that, we're depriving ourselves of years of life and quality of life as well. But I joke with my patients all the time. I say, I have a drug that's going to make you stronger. You're going to have better posture. You're going to lose weight. You're going to look better. You're going to sleep better. You're going to feel better. And they're like, give me that drug. I'm like, sorry, it's called physical activity. So that's the drug. That's the drug. So
do we have a couple more
It's
questions?
similar to what we just were talking about, but how do you maximize healing after the procedure?
I think we talked about that, physical therapy.
Those are good. Yeah. So, but you could ask, how soon? So it depends on the injury. So in the case of osteoarthritis, many patients will have a short-term flare in their symptoms after we do an injection. I mean, basically any injection has the potential to flare the tissue for 2 or 3 days. That's typical. So moderate pain for 2 to 3 days, maybe requiring ice and Tylenol, that kind of thing. I generally advise my patients to decrease their physical activity, maybe cut it in half for a week, and then advance based on their symptoms. I've never had a patient push themselves so hard that they have exacerbated or worsened the condition, or perhaps ruined the potential for a good result. But I've had patients flare it up enough to where, you know, they maybe lost a week of their rehab because they flared it up too much. You know, unlike surgery, where, say, if you're doing an ACL reconstruction, you know, cruciate reconstruction in the knee, or, you know, rotator cuff repair, where you're trying to protect that surgical repair for a period of time and you're immobilizing the patient, we're not doing those kinds of procedures. So when we inject a tendon or inject a ligament, you pretty much can use it within days without fear of re-injuring yourself. So we just let people let pain be their guide. But generally speaking, the first 2 to 3 days you're sore, and then a week later you initiate your physical therapy program, and you're progressing your motion, your mobility, your flexibility, and then you're progressing your strength as tolerated, and then getting into the more advanced sports-specific training after that, once you're ready for it.
Yeah, great. I know people's attention span is short, so I'm going to ask you if you have anything else you'd like to share with our audience about stem cells that you feel is important for them to know, or cutting edge, or...
Well, we've hit many of the highlights. I would like to add that although stem cell therapy does require FDA approval in the United States, and no physician really has the right to offer you mesenchymal stem cell therapy, high dose, you know, culture expanded here in the U.S., there are some specific programs for which patient may qualify. There are clinical trials ongoing for which patients may qualify. So we can help guide them to those locations. The ability to bank your own cells today is available. So I have had my fat, not all of it, but a small portion of it removed, sadly. Not all of it, but enough to get 1 million stem cells in that little fat sample. And now I have my stem cells in hibernation in the freezer, and they will be there for the rest of my life. So if I, God forbid, have a stroke or a heart attack or something in the future for which my doctor thinks stem cells may be useful, you know, knee arthritis, what have you, I have that available to me now. And any patient can do that now. It's not cost prohibitive. There is a cost, but it is fully permitted by the state medical board and by the tissue licensing boards, which oversee the whole process.
Fantastic. I know cell banking it's going to be a game changer for sure. I'm glad you mentioned that. We're going to put up your website. People can find you. I think it's like sdomg.com. And
Yes.
We'll put it in the show notes too. But if you're interested in PRP, stem cells, cell banking, anything else, and you want to contact Dr. Rogers' office, that's how you can do it the best way, I believe.
Yes, absolutely.
And we'll make sure it's in the notes too. And if you have any other questions, you can put it in the notes after. And if I can't answer it, I'm sure Chris will be generous enough to answer again. But I think that if you are suffering from an orthopedic problem that is changing the quality of your life enough, I think that investigating these biologic injections should be something you should consider, because it's got a high rate of success, low risk. And I also, if personally, I would get myself to Carlsbad, California and see doctors in his group who are really, really good. So again, I want to thank you so much, Chris, for joining us. And I'm hoping we can do this whenever there's something, fireworks go off and you're like, wow, we got to let people know this. It'll be on our site, your site. We'll make sure as anybody who we can get to can and learn about it. So thank you again for joining me.
My pleasure, Kate. My pleasure, Kate. And if you have viewers who don't live near San Diego, I personally and our company, Personalized Stem Cell, are well connected to dozens of doctors around the country who are also involved in what I'll call FDA compliant evidence-based stem cell therapy and are practicing with the highest, standards. So I can help refer patients to as well.
Fantastic.
So don't hesitate.
I know I bug you about that often. Do you have somebody really get in?
Yes.
Thank you.
Yeah.
Thank you for offering that. That's really generous.
Of course.
Thank you all for joining us. We'll be back next week with another Move Without Limits podcast. And stay tuned. Our goal is to bring you the latest, the greatest, and the best information so you can enhance the quality of your lives. Stay tuned. Thanks again. Before you head out, I'd love your help. When you like, when you share, when you subscribe, it's not just a click, it's a gift. Every tap helps this message reach someone who may be sitting in pain, wondering if they'll ever move without limits again. So go ahead, hit that button now, and let's keep moving together.